Okay, good afternoon, everyone. It's 1 o'clock, so we're going to get started. My name is Allie Wells. I'm the Communications Director at the Foundation for a Healthy Kentucky. Thank you for joining Health for a Change, Understanding Genetic Counseling and Cancer Care. I want to thank our speakers who have dedicated their time and energy into putting together today's presentations. I'm going to turn things over to them in just a few minutes, but first, I've got some quick housekeeping notes I want to go over with you all. So there are no pre-approved CE credits attached to this webinar, but I can provide a certificate of attendance for joining today. To get that certificate, you must stay on for the full duration of the webinar. You must be registered under your own name if you have joined using a coworker's link. It's their name that we're going to see in our attendance report, so we wouldn't be able to verify your participation. And certificates are only available for joining the live webinar. If you are watching later from YouTube, I'm sorry I cannot help you there. And to get that certificate of attendance, you can scan the QR code that's up on your screen right now. There's just a quick little form you have to fill out with your name and the title of today's presentation. I'll also include all of these instructions in a follow-up email with a link to that web page and a link to the recording from today. Just to tell you a little bit about the Foundation for a Healthy Kentucky, we are a nonprofit organization funded by an endowment. Our mission is to address the unmet health needs of Kentuckians, and our two focus areas are access to care and children's health. We do our work through policy advocacy, we build partnerships and bring together constituency groups, we fund research and data, and we also fund and support community intervention and projects that improve the health of Kentucky communities. I'm going to stop sharing my screen right now. And so within our access to care focus area, one of the things we do is we work to address access to cancer screenings. And genetic counseling can play an important role in identifying cancer risk and helping patients and families make informed decisions about their care. So how can you help Kentuckians you serve get connected to this type of resource? Your first step was joining this webinar today. So with that, I'm excited to introduce our two speakers. We've got Disha Patel and Lydia Pack, and they are both senior oncology genetic counselors at the University of Kentucky Markey Cancer Center. So with that, I invite them to kick off their presentation.
Okay, perfect. Well, thanks for the introduction, Allie. So, like Allie said, our talk today is titled Healthy for a Change, Understanding Genetic Counseling and Cancer Care. So I'm going to go through the first part and then I'll hand it over to Lydia and we'll be back at the end for communal questions. So next slide for me, Lydia. Okay, so neither of us have any relevant disclosures. Next slide. And then three objectives for this talk. So first one, explaining what genetic counselors do and the importance of genetic testing for patients and families, particularly in the oncology space, explore how to talk to people about genetic counseling and genetic testing and when people should consider seeing a genetic counselor, and then describing the nuances to conversations about genetics using case examples. Next slide. So what is genetic counseling? So we'll kind of go through a few slides and we'll go through the details of what a genetic counseling session looks like and the types of conversations we tend to have. Next slide. So genetic counseling has a main component considering an individual's personal cancer risk. An individual's personal cancer risk is driven by a number of different factors. Some of what causes cancer is truly just random chance. Some of it is older ages. As individuals are getting older, the risk for cancer increases. Some of what causes cancer is lifestyle or the environments we live or work in. And then a portion of cancer can be explained by the family history or genetics. And so in genetic counseling, we're really focusing on those two components to identify how they play a role in an individual's personal cancer risk. Next slide. So we tend to highlight that most cancer, 70 to 80% of all cancer, is really just sporadic. It's occurring by chance. It's explained by one of those other factors. Even smaller portion of cancer, 15 to 20%, is familial, which we tend to think of as family members sharing similar environments or similar immune systems, contributing to their overall ability to develop cancer. And then 5 to 10% of all cancer is hereditary, which is where a gene mutation is passed down through generations of a family, predisposing an individual to getting certain types of cancer, getting them earlier or getting them more frequently. And we tend to focus on that hereditary aspect of cancer in our genetic counseling sessions. Next slide. So with genetic counseling, we often meet patients for what's called a pre-test genetic counseling appointment. It's typically an appointment where we go through a lot of different things and then we talk about what genetic testing is. We educate them about the genetics of it all. We consent them to the testing. We collect a specimen or coordinate collecting a specimen for testing. We talk about the different types of results. We collect family history and personal history information. And then after that, once we get their sample at the lab, 3 to 4 weeks after that is when we get results and we follow up with them to discuss those results and any specifics associated with those results. Next slide. So we start a genetic counseling session by building rapport. This just helps us understand what information a patient is coming into the session with, if there's any specific concerns they have, and also just helps us understand their goals for genetic testing. Some patients have really specific goals and it helps us, tailor the results conversation or tailor the general appointment to their specific needs and personalize that conversation. We also spend a good amount of time collecting personal and family history information. The personal history information helps us run risk models, more specifically for things like breast cancer, to understand if there's a risk associated with an individual's personal history factors, separate from genetic testing. And so oftentimes all of that information is utilized for that. And then also the personal history information helps us understand what types of screenings a patient might have completed in the past, and helps us know kind of, again, how to tailor that conversation on the post-test side. We also spend a good deal of time collecting a family history. So we collect family histories in what's called a pedigree. So that's the chart here on the screen. And here circles are individuals assigned female at birth and squares are individuals assigned male at birth. And then the color shadings are often indicating the types of cancer an individual has. So I know Lydia will have some case examples and she'll go through the specifics with them. But these specific trees help us see different family histories and see if we're seeing any patterns or any things that would raise our general concern as we look at them. Next slide. And so really when we look at these family trees, there's a couple of things that we're looking for, and this can be helpful as you all are talking to patients in the community, if they have any of these things, or if there's generally even a concern about their genetic risk for cancer. These are the main things that we're looking for, but then also anyone who has any general concerns we're able to see as well. But the things that we're looking for in these pedigrees is anyone diagnosed with a young cancer, so specifically breast, colon, or uterine less than age 50. Does anyone have a rare cancer type? So an ovarian cancer, a male breast cancer, a pancreatic cancer, a medullary thyroid cancer, or a pheochromocytoma? Does anyone in the family have multiple primary cancers? So that would be 2 or more primary cancers in the same person. Or in the extended family history, is there any Ashkenazi Jewish ancestry? There are certain gene mutations that are found more frequently in that population. Or do family members have the same or related types of cancer? Many of the cancer genes that we test for, they protect against more than one type of cancer. So if we're seeing a general trend for multiple types of cancer, it can raise our suspicion. So some examples of that would be breast and ovarian, breast, thyroid, uterine, breast sarcoma, brain, or colon and uterine cancer. Next slide. And so all of that information helps us identify if a patient is eligible for genetic testing. We often use National Comprehensive Cancer Network criteria. Most conditions, cancer conditions do have NCCN criteria, but there are other governing bodies we can utilize. And really on the NCCN criteria, it's just a bunch of text telling us when a patient is appropriate for genetic testing versus not. Often this is the same criteria that insurance is utilized to say if they will pay for testing. Just because a patient doesn't meet the NCCN criteria, it doesn't mean that they can't get genetic testing. There can just be some nuances or some additional ways that we might go about getting them coverage for testing. Next slide. And then we spent a good deal of time talking through the genetics pieces of it. And so the genetic information that we tend to look at. We talk about how, all of these genes that we're looking at, what are the genes? Because a lot of our patients, they haven't had a genetics class in many years, or they haven't had um, they don't recall their genetics coursework. And so we're going through the genetics pieces of what we're looking at. Most of the genes that we're looking at are called tumor suppressor genes. And so their whole job in the body is to stop cancer from developing. And if there's a gene mutation, that's where individuals are at an increased lifetime risk from developing those cancers. Here, we're really going through a lot of the more common myths associated with the genetics of it all. So I think oftentimes I hear patients saying, like, oh, my friend heard that she has the BRCA2 gene. And it's really going through and saying, well, everyone has the BRCA2 gene. So this testing we already know that you have the BRCA2 gene, but this testing is helping us identify if you have a gene mutation that's stopping the gene from working. And then going through the fact that sometimes this testing, patients have a misconception that it's going to tell them if they have cancer or not. And this testing is more so just telling us, do they have that gene mutation? And then if so, is it going to place them at an increased risk over the average person to develop a cancer? And so that's the main conversation there. And then also highlighting that a lot of the cancer tumor suppressor genes are inherited in an autosomal dominant fashion, which means one gene mutation from one parent is enough to have symptoms of a condition or be at an increased risk for cancer in this case. And so highlighting that the familial implications that they likely, if they have a gene mutation, have gotten it from one of their parents, and could be sharing that with siblings or passing that on to their children as well. Next slide. Another part of the genetic counseling process is the mutual decision-making process. There's lots and lots of different types of genetic testing options. And so going through what is the most appropriate, and that's something that genetic counselors are really trained to do. So most often we're offering patients what's called multi-gene panel testing. This allows us to look at several different types of genes associated with different types of cancers that we might see in the family history or not. So most often we're either offering a 40 gene panel or a 77 gene panel. Those two panel options have different nuances. Some of the cancer genes are really well known. We have really great screening and really well-defined guidance about how to manage those increased cancer risks. Some of the genes are more newly discovered. Screening might be more broad, or it might be recommended to be initiated later in one's life, or might not have regular intervals of repeating it. So going through those nuances and the specifics with each patient based on their personality and their feelings about learning information that might have less clear guidance. And then we also offer what's called site-specific testing. So if we're seeing a patient and there's no family history of cancer on their mom's side, and their dad had gotten that expanded testing with only one gene mutation, it might feel appropriate to do site-specific testing where we're just looking for that mutation that's in their family. And then we are not often offering single gene or syndrome testing. It's something that is limited and might not look at the whole family history. There are certain instances, for example, we see patients for what's called stat breast testing, which is where they've recently got diagnosed with a breast cancer, and then we're seeing them to discuss genetic testing and see if it would change anything for their surgical implications or medical implications. And in those instances, sometimes patients say, well, like, I don't want to focus on anything except breast cancer right now. And we have a, very honest conversation with them about the fact that if we do just the breast cancer testing, we might not be looking at all of the other cancers, and it might be limiting. And so single gene or syndrome testing is usually not recommended. And even when we're offering it, it's usually against recommendations, and we make sure that we're communicating that. But we do get a lot of patients who have gotten testing externally that have gotten single gene or single syndrome testing. And then we're kind of talking to them about, your testing was limited and now we need to go out and do this expanded panel. So we often work with a lot of community partners to ensure that, if they've gotten the wrong testing, that they're seeing us, and they make sure that they're referring future patients to us. So to make sure they're getting the most accurate or appropriate testing in their specific case. Next slide. A good deal of our conversation focuses on the logistics. So we see patients all across the state of Kentucky. We see patients in person via telehealth as well. And so when we see patients in person, we're often grabbing a blood sample. And then if we see patients on telehealth, if they live far away, sometimes they might opt for a saliva sample. It's most convenient for them, but we do offer them the option of returning to Lexington to do a blood draw. Blood samples and saliva samples, patients often ask, like, what is more accurate? And both are equally accurate. There is just an extra analysis that we can do with blood that we can't do with saliva. And that extra analysis has a 4 to 5% extra yield. And so keeping that in mind, we're often encouraging our patients that if it's possible, if they have a follow-up appointment, or if there's anything that we can do to help them return to Lexington to do that blood draw, that can be easier. And then if patients have an active hematological malignancy, for example, like an active leukemia, or they've gotten treatment for a leukemia lymphoma with a stem cell transplant with a stem cell transplant, then we often have to coordinate doing a skin punch sample. And so there's definitely nuances in what sample type can be appropriate, and we spend some time talking about what is appropriate and what might be most convenient for patients. We also talk a lot about the billing. I have patients that come in and their first question is, well, how much is this going to be? Because I've heard that genetic testing can be thousands of dollars, and there certainly was a time where it was thousands of dollars. But these days, genetic testing is more accessible, especially if patients meet the National Comprehensive Cancer Network criteria. There is pretty good, great coverage for testing. Most of our patients are paying less than $100 based on what we have been presented from the laboratory. But if patients ever have a bill over $250, they're able to reach back out to the laboratory and utilize the laboratory self-pay cost of $250. That cost uses the patient just paying the laboratory directly versus using their insurance benefits. So it's not utilizing their insurance benefits, and it's a good way for a lot of our patients that don't meet criteria to get access to testing. Some of our patients say that if $250 is nothing for the peace of mind, and so that's accessible. But then there's also a great financial assistance program through our laboratory, which helps a lot of patients get access to testing as well. Next slide. And as the name implies, a big part of our profession is the counseling side of things. So learning this information about oneself and knowing that they could be at an increased risk for cancer is definitely a large piece of information, as well as thinking about the implications of testing, whether that be like surgical changes or management changes, the increased screening, or just the feelings of seeing a family member with cancer and having the anxiety about developing that yourself, or the guilt of passing down something to children or sharing that with relatives can definitely be psychosocially heavy. So we are trained in providing psychosocial counseling to patients about specifically genetic testing. But if there are any needs that we feel like that are unmet by our conversation, we are often relying also on our social work team here at UK and sending patients to them and helping them connect with community resources should they need anything. And then we also talk about the legal implications. There is a law in place called the Genetic Information Non-Discrimination Act, or GINA for short. This law helps provide protection against health insurance or employer discrimination. So, for example, if patients are identified to be positive, their health insurance can't drop them or deny them coverage, or their employer couldn't fire them. The same law does not apply to life insurance, long-term care, or disability insurance. And so we talk about that and talk about if that's something that they would want to consider before getting their testing. Also talking about the specific limitations that the law doesn't apply to everyone, and talking about all of those specifics with patients is definitely a part of almost every session for me. Next slide. And so these first five chunks on this slide are the pretest appointment, and then we're talking about the types of results and how to follow up. So like I said, 3 to 4 weeks to get results. And the next slide. When we get a genetic testing result, there's about 5 different results we can get from the result itself, and then they mean 3 different things, and then they have different implications. So starting all the way at the bottom on the left-hand column, there's two things that mean negative. So if there's nothing identified, no variants detected, or no gene mutations identified, that's a negative result. Or if they found a change and based on the laboratory's data and the available research for how those variants are assigned, if they're greater than 90% sure that it's not cancer causing or likely benign, they associate that with a negative result. There's also a middle result there. It's called a variant of unknown or uncertain significance, or a VUS. A VUS result is where they found a change in one of the genes. They just aren't sure if it's associated with an increased risk of cancer or not. Most of the time, 90+% of the time, those types of changes get reassigned to a negative. So I often tell patients, I think of them as like innocent until proven guilty. We don't change anything, we don't do anything differently or test other family members based on just that result. With both the VUS or negative results, medical management changes can be made based on an individual's personal or family history. So that's where we're running those risk models to see if there should be any changes based on an individual's personal history or their family history, and we're able to recommend those things. And so that's where a lot of times, even if we're not concerned about a family history, seeing patients for genetic counseling can be beneficial to just run those risk models or have those conversations as well. And then the top two results that we can get on the report, so the top two boxes there, is a variant that's either likely pathogenic or cancer causing, so greater than 90% sure that it's cancer causing, or a pathogenic mutation, so a cancer causing gene mutation, and that's associated with a positive result. At that point, we're making changes based on an individual's gene mutation. So what are the recommendations per governing bodies? Do they need to be sent to any high-risk clinic? Should we test other family members? What are the general screening or management changes we might make for them? And so there's lots of instances where we see patients and they're like, we look at their family history and we don't think that they're going to be positive, but then things can definitely surprise us. And I know Lydia has some case examples. And so that's where I always tell patients, like, the proof is in the pudding. The genetic testing is the best way to know. But with our pre-test conversation, we're able to provide them a sort of risk assessment for what our thoughts are. And then of course, when we get the results, we're able to give them more specific. So we tend to, if our patients are positive, we tend to meet with them again, either in person or via telehealth, to discuss those results, just so they have a set time that they're able to talk about those results. And then with negative and VUS results, we often send those out via MyChart message, but we can also meet with patients based on their comfort level with MyChart or just their general curiosity and personality. Next slide. So for high-risk clinics, which we have some of them at UK, these high-risk clinics, I'll talk a little bit more about them on the next slide, but we're sending patients there for three different reasons. Number one, if they have a known cancer syndrome, so if they have a BRCA2 gene mutation, we want to send them to a high-risk breast clinic or gyne clinic for follow-up of that gene mutation and its next steps. If they're at an increased risk based on their family history, so if they have a parent and a sibling with pancreatic cancer, or like a first-degree relative with their own first-degree relative with pancreatic cancer, or if they end up being at an increased risk based on those personal risk factors. And so based on those risk models, if they're at an increased lifetime risk, there can be some management changes, and a high-risk clinic would be the appropriate setting for them to be seen at. Next slide. So these high-risk clinics, they're utilizing NCCN guidelines or guidelines from other governing bodies or literature we have to follow these patients. And the whole goal of these high-risk surveillance programs is to detect cancer at its earliest stage, reduce the risks, and make sure that patients are being followed with appropriate surveillance, and making sure that as different services are needed for these patients, that they're being referred as quickly as possible. So a lot of this management is multidisciplinary. At UK, a lot of our high-risk clinics our patients are being followed by APRNs or NPs, and they're also referring to oncologists or surgeons if there's any of those implications. And then we also rely heavily on our primary care provider partners. Patients sometimes live further away. They're only returning to UK once a year to get these screenings, but the rest of the year they're seeing their primary care provider. So primary care providers are that great in between for patients to be seen, and if there's any concerns for them to address those concerns and ensure if they need more immediate follow-up for these cancer risks. So when a patient is positive, we're sending them to these high-risk clinics, but we're also sending their results back to whoever referred them, their primary care team, and just making sure that it's in their medical record for anyone to see. At UK, we have our high-risk clinics divided by specialty. So we have a high-risk breast clinic, a high-risk GI clinic, a gyn-onc clinic. And this is helpful because it allows patients to have more specialized care based on their specific needs. But it can be sometimes a hassle if they live further away and have to return for multiple appointments. I've heard from some patients that they've been able to coordinate everything on the same day, but a lot of institutions have high-risk surveillance programs. So even if a patient didn't want to return to UK or they lived closer to a different higher surveillance program, some institutions also have one clinic that sees all of the high-risk patients versus specialty clinics. And so that's definitely an option at some institutions as well. Next slide. Okay, perfect. I'll hand it over to you, Lydia.
Hopefully you all can hear me okay. Thanks so much, Disha, for your part of the presentation. So I'm going to transition and more so talk about like how to talk to people about genetic testing or just cancer genetics in general, as well as talking about some different case examples of patients we've seen and some how that can be applicable for other providers to talk about genetics, as well as just give some key takeaways about hereditary cancer in general. So without further ado, the first thing I want to start off with is just some numbers to represent how common hereditary cancer is. So in general, 1 in 3 people in the United States will develop cancer at some point in their lifetime. 1 in 279 people in the United States have a specific syndrome called Lynch syndrome, or what's also called hereditary non-polyposis colorectal cancer, which I'll give a little bit more information about on the next slide. But main takeaway is that it's a hereditary cancer syndrome that increases someone's risk for colon and uterine cancer, as well as some other cancers we think about with that. And then about 1 in 400 people in the United States have a BRCA1 or BRCA2 mutations. And in certain populations, that risk is significantly higher, such as the Ashkenazi Jewish population, which is what Disha brought up earlier. And with BRCA1 and BRCA2, the most commonly thought of cancer risks associated with those two genes is breast and ovarian cancer, but we do know of other cancer risks with both of those gene mutations. And the reason that I bring up both of the Lynch syndrome and BRCA1, BRCA2 is because they are the most common hereditary cancer syndromes, but we do know of quite a few other hereditary cancer syndromes, which is why we do the multi-gene panels. So I'm not showing numbers there, but hereditary cancer syndromes are fairly common is the main takeaway. So this just gives us a little bit more information about Lynch syndrome. As I said, 1 in 279 people are estimated to have this. They're caused by what we call germline pathogenic variants or mutations in these specific genes called mismatch repair genes. And those 5 genes are listed there. As I said, the biggest cancer risk that we think about with someone who has Lynch syndrome is colon and uterine cancer, but each gene has its own specific risks associated with them. So some of those risks are higher for each specific gene. So some of them may more so be associated with colon cancer or some more so associated with uterine, as well as you can see the other cancers that we think about with Lynch syndrome. The benefits to doing genetic counseling and genetic testing, we've kind of already highlighted some of that, but I just wanted to further emphasize that having knowledge of preventative measures that you can do to reduce your risk of cancer is significant, whether or not someone has a hereditary cancer syndrome or not. Disha talked about how even if someone has a strong family history of cancer and they don't have a hereditary cancer syndrome, they may still qualify for high-risk screenings, and that can definitely reduce someone's risk of cancer, or they may be able to catch cancer earlier if someone ever was to develop it. As well, risk-informed cancer screening reduces people's cancer mortality and improves overall patient outcome. So some examples of this is people who have a BRCA mutation may elect to have what we call a bilateral salpingo oophorectomy, which basically just means they have both of their ovaries removed. And this can reduce their risk of developing ovarian cancer by 90%. which increases their overall survival and cancer-specific survival if they have this surgery. So knowing whether or not someone has a BRCA mutation is really important because we know they have such a significant risk of developing ovarian cancer. Another example is that for people who have Lynch syndrome, if we do increased frequency of colonoscopies in people who have Lynch syndrome, their incidence of colon cancer decreases by 62%. Because when we do a colonoscopy, we often take colon polyps that can develop into cancer. So having those increased screenings in people who are at high risk for colon cancer is very significant in reducing their risk of ever developing a colon cancer. Other benefits to doing genetic counseling and genetic testing includes that if someone does have a hereditary cancer syndrome and they currently have cancer, it can actually impact their cancer treatment. So there are certain medications that we think about for someone who has a BRCA1, BRCA2 mutation called a PARP inhibitor. And people who have Lynch syndrome may be eligible for what we call immune checkpoint blockade therapy. So knowing whether or not someone has one of these hereditary cancer syndromes when they have cancer is especially useful. And as Disha already highlighted in the beginning, having the psychosocial and familial support that comes along with genetic counseling, oftentimes people are, even if they don't have a cancer diagnosis, can be overwhelmed by having the idea of thinking about they're at higher risk for cancer. Or if they find out they have a hereditary cancer syndrome, they may struggle to think about how to talk to their family about that information. So we often support people, talking about how they want to discuss these results with their family. We even can write letters so that they can share those with their family. So definite benefits to meeting with the genetic counselor to work through those issues. So now I'm going to go through a couple of case examples as well as some things that we hear from patients. So the first one that I wanted to highlight is when someone says, I don't have a strong family history of cancer, why should I consider testing? And in this case example, someone actually, this specific patient who's represented with this black arrow here, if you can see my cursor, actually does have a somewhat significant family history of cancer on mom's side of the family, but we'll talk about why that's a little bit less relevant for this specific situation. But as a genetic counselor looking at this patient's pedigree or their family history, we see that the patient has a papillary thyroid cancer in their 30s. There's some family history of cancer on mom's side that's a little bit concerning for hereditary cancer syndrome, such as this young gastric cancer. And some of these other ones we think about as being more lifestyle related, such as like lung cancer. We denoted that there was tobacco exposure, so likely that had something to do with that. And sometimes like skin cancer, we assume, although some are hereditary, by and large, most skin cancers are caused by like sun exposure or just a familial genetic predisposition. So in this person's case, they actually didn't meet that NCCN criteria that Disha mentioned to do genetic testing, but they opted to have genetic testing anyway, and they were actually found to have a BRCA2 mutation. And so we know, as we've talked about, this is significant for someone because not only does it significantly increase their risk for female breast and ovarian cancer, it's also significant for male relatives because it increases their risk for male breast cancer and prostate cancer, as well as for anyone, it increases their risk of developing pancreatic cancer at some point in their life. So definitely significant not only for the patient, but also for her family members. So family members actually decided to get genetic testing, and we found out that her brother also has the same BRCA2 mutation, but it wasn't inherited from her mom. So her mom had the same test and she was found to be BRCA2 negative. So we probably can assume at this point that it was inherited from her dad. And actually on dad's side of the family, there wasn't a significant family history of cancer that we knew about. So it just goes to show you sometimes when we don't know a ton of family history, or even if we don't have a super strong family history of cancer, someone may still have a hereditary cancer syndrome, which is why we say that anyone can consider genetic testing, especially because we know it's just so common. And we've kind of already talked a little about this, but in a situation where someone already has cancer, someone may ask, what's the point in finding out if it's genetic or if it's hereditary? As I discussed, it can affect treatment decisions in terms of like medication options. They may be eligible for clinical trials if they have a hereditary cancer syndrome. But it also can impact like what other screenings we would recommend for that person or other surgical decisions that they make. So for example, if someone found out that they had a hereditary cancer syndrome and they had breast cancer, they may opt to do a more invasive surgery or having like a bilateral surgery in order to remove both breasts because they would know their risk of developing breast cancer is higher than the average person's. It also can tell us, even if it doesn't impact the patient necessarily, which most of the time it does, it can also tell us for other family members if they're at risk at developing the same type of cancer or other types of cancers that the patient has. So to give an example of this, in this specific patient, she actually had developed colon cancer in her 40s, which did meet criteria to consider genetic testing. Her family history was somewhat suspicious for hereditary cancer syndrome in that she had a paternal aunt with a young breast cancer, so you can see that up here. And the mom's side of the family was less concerning. There was just someone who had colon polyps, her maternal uncle up here. So she opted to do genetic testing, but we found a pretty surprising result. And this was actually she had a gene mutation in a gene called BRIP1, which actually has nothing to do with colon cancer or breast cancer. So this actually didn't explain why the patient had developed breast cancer, but because we did a big panel test that found this gene mutation, we then knew that the patient was at a pretty significant risk of developing ovarian cancer at some point in her lifetime. Even though there wasn't a family history of that we knew about, because we did genetic testing for her, we were estimating her risk of developing ovarian cancer to be about 5 to 15%, and the average person's risk is about 1%. So because of this, the patient actually did decide to undergo a bilateral salpingo-oophorectomy to reduce her risk of ovarian cancer, and because at that point she was done having children. Some other things that we hear from patients about concerns about considering genetic testing or thinking about genetic counseling is that they are concerned that they're going to go into the appointment and they don't know enough about their family history, or maybe they know nothing about their family history because they were adopted. Even for anyone you talk to who's interested in genetic testing, there, as Disha talked about, are somewhat reasonable self-pay prices for testing. So even if someone doesn't use their health insurance, oftentimes the maximum they're paying for genetic testing is $250. And sometimes also we can use the fact that someone doesn't know their family history or only has a limited family history as a reason for health insurance to cover doing genetic testing. So even in a case where someone's concerned that they might not be eligible for testing, we can sometimes try to get health insurance to cover doing it anyway. And I also wanted to address this something else that we often hear, or some way to talk up to others about genetic testing, is the thought about testing children for hereditary cancer syndromes. So oftentimes if a patient tests positive for hereditary cancer syndrome, they reasonably want their children to get tested for it as well, so they know if their children are at risk of having that same hereditary cancer syndrome. However, if their children are under the age of 18, there's this statement that was written by the American Academy of Pediatrics where they say genetic testing for adult onset conditions generally should be deferred until adulthood, or at least until an adolescent is interested in testing and has developed mature decision-making capacities. The main reason that we think about deferring testing is based on that GINA law that Disha talked about earlier, and thinking about like oftentimes young children don't have life insurance policies set up already, and that might be something they want as an adult, and so they may want to wait to have genetic testing until they're older to make sure that they can get those policies that they might not otherwise be eligible for, as well as just preserving patient autonomy. However, there are quite a few conditions in hereditary cancer genetics where it would be warranted to consider genetic testing for children if we know that there are screenings that we should be doing in childhood, or if there's a pediatric childhood cancer risk. So I'm going to talk about one of those examples. There's also situations where if a child has already had cancer at some point in their lifetime, then it may also be in that case warranted to consider genetic testing. So this condition that I'm going to talk about is called familial adenomatous polyposis, or FAP for short. This is something that we do test children for because the screenings are actually recommended to start even from birth, including having colonoscopy starting from the age of 10 to 15. Why we start screening so early is because when someone has FAP, they have a risk of developing hundreds to thousands of colon polyps in their lifetime, or in what we call classic FAP. They often require surgical intervention in order to manage the colon polyp burden. And there are other situations where someone might have attenuated FAP, so they may have less colon polyps than we typically see with someone who has classic FAP. The average is about 30 in a lifetime. And this is likely underdiagnosed because a lot of people, if they don't have that significant colon polyp burden, aren't as concerned that it's actually hereditary. There are some other syndromic features that I've listed here and have some pictures of that are associated with FAP. But the main takeaway I want to present here is that there are conditions that can impact children and that we do sometimes test children for. And then I just also showed this chart that goes through the cancer risk that we think about for FAP, highlighting the fact that there is a known liver tumor risk called a hepatoblastoma that only affects children. So that's why it's important for someone who has a family history of FAP, and FAP is actually more common than one might think. For someone to get tested as early as infancy because we know they have that risk of developing a hepatoblastoma even as a young child. So if you're talking to a patient or if anyone you know is interested in genetic testing and they wondering how do I go about getting genetic testing, at the University of Kentucky, for cancer genetics, we do accept self-referrals. So sometimes we prefer having records, especially if someone's from an outside institution. So if they're able to get a referral from a primary care provider that they see, that's great. But we know also that there are plenty of patients who may not have a primary care provider, that may not be feasible to get into their primary care provider quickly. So we do accept self-referrals. So all someone has to do is just call our clinic and say, I have, a strong family history of cancer, or I don't know my family history, and I'd like to schedule an appointment. And I've listed the phone number there to call our clinic to schedule an appointment. There are other cancer genetic counselors in the state of Kentucky, and there are tons of genetic counselors around the country and even around the world. So there's this great website from the National Society of Genetic Counselors that I've listed in this second bullet here called findageneticcounselor.nsgc.org. So if someone's outside of Lexington or they're trying to find somewhere closer to them, or if they're outside of the state of Kentucky, they could use this website to find a genetic counselor that's closer to them. As Disha said in the beginning, we will see anyone in the state of Kentucky, and we even see patients from surrounding states that will either come in person to Lexington to be seen, or they might commute across the border to do a telehealth appointment. There are other specialties of genetics, like neurology genetic counseling, cardiac genetic counseling, the general or pediatric genetic counselors. But these specialties do often require referrals from a physician, and is obviously not our subject matter that we're talking about today, but also just wanted to emphasize the fact that genetic testing, there's lots of genetic diseases out there. So if you have, or you or anyone you know has a history of a genetic disease and is interested in talking to someone, that website can also be used to find a genetic counselor in other specialties too, or talking to your primary care provider, talking to the patient about talking to their primary care provider is another great way to go. So the key takeaways I hope you take away from our presentation today is that number one, hereditary cancer syndromes are incredibly common. Also, because of this, anyone can meet with a cancer genetic counselor. So I hope that I've showed some instances of where it may be important for someone, even when they don't have a significant family history of cancer, to consider having a genetic counselor meet with them to talk about what screenings they might be eligible for. Also, having the knowledge of a hereditary cancer syndrome can be empowering. Oftentimes it is daunting as well for someone who is thinking about having genetic testing, But by knowing if someone has a hereditary cancer syndrome, it allows them to have insurance coverage to do the recommended screenings, and it also gives them the knowledge on how to be as preventative as possible for their health. The last takeaway I hope I leave you with is that anyone can discuss personal and family history of cancer, and anyone can talk about referring a patient or giving them information about cancer genetics. So I know that a lot of the people on today's presentation may not, cancer genetics is maybe not their specialty, but if you're talking to a patient and they bring up, concerns about their personal or family history of cancer, it may be worth discussing a cancer genetics referral with them.
And then these are just some great general resources. So there's the American Cancer Society has a great link talking about the genetic testing for cancer risk. And then a lot of these other institutions are, or not institutions, other links, they were created for advanced practice nurses or for nurses. And it's just helping them talk about genetics or genetic testing so it can be utilized for really any provider that sees patients or just anyone that's curious on how they might be communicating that. And then, of course, like Lydia has said, we are happy to be a resource. Our contact information will actually be on the next slide. And then the National Comprehensive Cancer Network has all of the greatest guidance that we could ever need for knowing whether testing is appropriate or not. So sometimes when we've given this talk in the past, that has been a helpful resource for some providers as well.
And I think we can take any questions if anyone has any.
Yeah, any questions from the audience can go in the chat or the Q&A box. And while we wait a second to see if any come up, I'm going to add the link of where someone can request a certificate of attendance for joining today, just so that you have that. But Lydia, Disha, I found that incredibly interesting, so thank you. We'll wait and see if we get any questions for just a moment.
I actually see one that just came across. So it's since the genetic testing technology is improving constantly, how often do you suggest being tested? And you have interpreted many genetic counseling sessions and translated. So yeah, we definitely think, if number one, thank you so much. Our interpreters, I think, are a cornerstone in us being more accessible to all the different communities. And it's always really helpful to hear certain words from someone like a native speaker. So number one, thank you. And number two, we see patients and we tell them to check in with us every 2 to 3 years after their results, even if they're positive or if they're negative, regardless of the results, or if anything changes with their family or personal history in the meantime. For a lot of our patients, like they have an easy way to contact us, like via MyChart or just like reaching out to us via phone call. And patients will reach out and say, hey, it's been 2 years. Has the testing like technology changed? Is there a cancer in my family that, previously was thought not to be hereditary or genetic, and could we now test for it? And so for some patients we're like, no, like as of now, like all the testing looks the same, we really wouldn't retest you. And for some patients we say like, actually, yeah, like you had a really small panel back in 2024 and now in 2026 there's a bigger option that looks at more information, so we would retest you. I don't know if you have other thoughts, Lydia.
Yeah, I think that I mean that covers what I think in terms of genetic testing, because definitely the technology is constantly changing and we are constantly learning more about new genes to test for. I also think that it's important for people to check in because our guidelines of how to treat people with hereditary cancer syndromes are constantly changing as well. It's just less than 2 years ago that people with BRCA2 mutations were recommended to start pancreatic cancer screenings regardless of family history. And that's just one example of how it seems like every year there's a new guideline that comes out. So definitely recommend, even if someone's had testing in the past, regardless of the result, like Disha said, it's worth them checking in with their genetics providers at least every couple of years just to see if there's any updates to guidelines or updates to genetic testing.
We've gotten a couple of comments in the chat about how informative this has been. So
Oh,
we love to hear that from people.
yes.
One question I have for you all is, you talked about how kind of accessibility has improved over the years since this got started. It might have used to cost $1,000. Now it's definitely more affordable than that. what are your hopes for like future improved accessibility?
I
If
guess
you
I
can
can,
answer that. So sorry.
yeah, no, you're good. That's a great question. I can start and then Disha, if there's anything you want to add. I think that the the NCCN guidelines for who's eligible for genetic testing are becoming more and more accessible, so that there's quite a few cancers now. If someone has a personal history of it, they automatically qualify to get genetic testing. And I think that's probably going to keep moving in the direction of more and more people being eligible for genetic counseling for their health insurance to cover doing genetic testing. There's even there's some other states that are doing some population health genetic testing. So I know in South Carolina, they're testing for Lynch syndrome and those BRCA1, BRCA2 mutations that I talked about that are incredibly common. And they're really trying to test everyone and anyone that they can for that. So I don't know if that's the future for Kentucky, because obviously there's some ethical nuances with that, but I think that is something that could be the future for people, if they want to opt into population health genetic screening, that may be something that comes in the future.
Yeah, I would agree with that. I think accessibility wise, I wish more people also knew about genetic testing or like the services of genetic counseling because I feel like sometimes I'll see a patient and I'll be like, man, how have you lived like your whole life? And you very clearly are, going to test positive and you have a really strong family history and all of these individuals have been diagnosed with this really rare cancer and no one has gotten testing because people like providers would just like brush past it or like didn't address it. So I would say like accessibility wise, I would also hope there's accessibility and like information about genetic testing or counseling, just so more patients can get access.
That's also a great point. One question came in. Who has the responsibility to keep up with recommended testing once someone does test positive? Is it primary care, specialist, the patient? Do you all have any notes on that?
I would say
Yeah,
honestly, oh, sorry, Disha.
no, you can finish your thought.
Okay, I was going to say, honestly, I think the people who are keeping up to date about hereditary cancer the most are cancer genetic counselors. It's hard to expect a primary care physician there or managing so much of someone's health and to expect them to also keep on top of like very specific hereditary cancer syndromes is probably a lot to ask for. So that's why we do recommend, even when like there are some physicians that will consider ordering genetic testing, but they may not have as in-depth knowledge as a genetic counselor does about genetic testing. So we typically recommend patients just talking to their provider, like a primary care provider, about meeting with a genetic counselor and not necessarily like a primary care provider ordering that testing. And yeah, that's why we recommend patients, even if they have a hereditary cancer syndrome, to check in with us every couple of years about keeping up to date with the guidelines because it's a lot to put on a patient as well to keep up with all that. But there are some good patient-friendly resources out there that do that. There's one called Force or Facing Hereditary Cancer Empowered that patients can like opt in to get like newsletters from them. But having a genetic counselor to talk to, I think, is probably the best. But Disha, any thoughts you have?
Yeah, I would also say our high risk clinics, I think, do a really great job of following up with patients and like they're also up to date because they're using the NCCN guidelines. So if anything changes, like in terms of their screening, they're keeping them up to date and they're like, they see them this year and then 6 months from now, if they need to see them again, they're already setting up that appointment. So um, it's, I would say like we are great resources, but then also with the screenings and all of those recommendations it falls a little bit on the patient, but then also it is a lot of information. So I think our high risk clinics are definitely a great intermediary for following up with patients with all those screenings and keeping them up to date.
Well, thank you both. I'm not seeing any more questions right now. So thank you for such an informative presentation, and thank you to everyone who joined and listened in. And with that, I'm going to wrap things up, and I hope everyone has a great rest of their afternoon. Thank you.
Thank you.
Yeah.